I'm humbled to be able to attend this conference. And I feel so happy that even with all the friends and colleagues who are now online, this hall still looks full, even with all the COVID protocols that we are taking. And thank you very much indeed. One of the reasons I came here is because I've attended more KD meetings than I'm likely to attend in future. There are fewer. However, talking maybe the last point, we really haven't discovered anything since the last talk a few minutes ago by Professor Munyao, Josiah, Priscilla, and all the beautiful speakers that we have had. However, at the end of the presentation, I'm hoping that we come out as a group, decided that we go forward, and like I said earlier on, that we put our country, our region, which we have actually pioneered, on the map, because there are a number of things that have come. At the end of it, most of the things, of course, I'm saying, I see the reviews done by Professor Dr. Waweru are actually from the recent guidelines. But knowing where we come from, knowing where we are practicing, and many people here are practicing maybe solo or maybe in county referral hospitals, the level 5s, we know that there are great difficulties that you personally, individually might not be able to attend. But I hope the association and all other colleagues, we can actually make a way forward like we have attempted in the past. You see, the talk today is psoriatic disease. This is going to be a paradigm shift, that instead of just talking about psoriasis, we are talking about psoriatic disease. And simply because of all the things that have been mentioned by all the colleagues and past presenters, because this underlines about the complexity of this problem. Others may say it is a syndrome, but I think ideally, if we define it like that, it will be easier. It is chronic, immune mediated, like all the presenters have said. It is inflammatory and affects actually most of the organ systems in the body. That is not new. However, since 2014, when we had the first psoriasis global report, which we have discussed severally in our meetings, where now psoriasis was actually labeled as a non-communicable disease, among others like diabetes, cardiovascular disease, mental illness, etc., etc. It is important that whatever treatments we are thinking about are pathogenetically based. That means the basis of the treatment we are proposing is based on what is the perceived pathogenesis. However, saying that, there's a caveat, because what really triggers the immune system, that yet hasn't been found, and that yet is going to be found. It is important, and one of the speakers mentioned, that there has to be long-term management. Patients will move from one clinician to another, and they are looking for quick fixes. This should not be the case. It is important to capture that. But having said that, it's also important to know that ideally, like I said earlier on, you don't have much time. If you are sitting in a clinic, for example, say the clinic, I was very familiar with the clinic number 17 or 23, and there are 6 of you, and you have maybe 70 patients to see. You can hardly spend a lot of time. For example, say, and of course we give examples where we know work has been done. In the US, as a dermatology consultant, you are actually only allowed maybe about 7 minutes You put a clock, 7 minutes are over. By that time, you have assessed the patient, you've taken the history, you have examined, and you have even written treatment. Is that possible? It is not. But a minute are the times when you have a queue waiting, and the patient says, actually, even before they sit, I've waited too long. But when they sit down, they are going on for an hour without even realizing. Okay? So these are instances that we know we are in, and we apologize for this. But we have, where there are challenges, there are, of course, opportunities and solutions. This is where we talked about referring these patients to patient groups which have more time. And we have many of our doctors in KD also in those groups, and they facilitate these meetings. So credible information is given. We do not allow people who come over and sell things in them also. Okay? Neither do we allow that a patient moves from Dr. So-and-so to Dr. So-and-so. Because basically, as I said, we want to uniformize or make uniform management so that the patient is comfortable when they are seeing you, when they are seeing somebody else. And they can tell you that when I was seeing so-and-so, I was told I had psoriasis, and this is the treatment I was given. But many of the patients will come over and want to trick you. Okay, that doctor gave me this, never told me what I have. But do you believe that, Lily? Please don't. But many times, of course, we are at fault because we are quick. We make your life by seeing numbers, obviously. But that patient to whom you make a difference is the one that will matter when you have retired. Retired for the day, not from the profession yet. Okay? Because you need to feel comfortable about it. Retirement, of course, is maybe still far off. If you have passion and you like what you are doing, you continue doing it until you are able to do it. Now, obviously, there's still a great need for such new and safe tools to use. I'm talking about tools of management. Yesterday, we had a beautiful presentation from the nurse practitioner that even as clinicians, we need to consider other people. And these people are actually spending more time with the patient than many times where we do. And they can have that additive role of reinforcing the things that you have said, the things you have suggested. We hope maybe the association KD will develop a patient pamphlet that tell. Well, obviously, health literacy is an issue. I mentioned about Dr. Ngugu, who is also very, very familiar and sometimes acts in contravention to the known practice that we have. But you do not even know what sites or what other previous was. Both sexes will be involved. This all had been said before. There are important references right at the bottom there that are good to know. And this is going to be passed off, obviously. Psoriasis does occur in children. It's not rare. So it's not maybe fair to say that probably under 40 and beyond 40. No. We are seeing it even actually in the Psoriasis Association of Kenya. We have parents who are coming with babies of 6, 7. Fortunately, we've been in, the association has lived, and some of them have transitioned into adulthood. And they are some of our best advocates. So it is important. The classification has gone into detail. This is not going to change because it's morphology based, and also maybe the classification also may be location based. These are clinical guidelines. Clinical guidelines that will tell you when you describe this and somebody else describes it, then you are actually talking about the same thing. That's the purpose of describing something. Otherwise, if you see it and you are the only one who will see, you can basically maybe rely on your memory or whatever. But we need to make sure that other people know what we are talking about. Some, of course, some of them are rare. Pustula psoriasis is rare. But there are 3 drugs, actually, one approved just maybe last week by FDA. But it is actually passed as a rare disease, because that is a route where you are not required to make a lot of randomized clinical trials. And that is something that the drug companies use. For us actually to have a big conference of psoriasis, it tells you that psoriasis is so important. Among the big pharma, you know, probably not what we are seeing here in our exhibitions, the people who make big money are in psoriasis, and in psoriasis with other comorbidities. So when you attend these conferences, psoriasis itself, particularly the non-biologic treatments, are probably put aside in the posters and where we present, because we present clinical material, not necessarily research-based. This slide has been passed on many times, but it's good that you know. At the corner of the slide, you will see that before we were being told that psoriasis is a disorder of keratinization, blah, 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 the thing, of course, has changed, because we are now involving the dendritic cells, we are involving the macrophages. And now we have the cytokines. And we are talking about tumor necrosis factor, interleukin things. If you are in a small practice in Kilifi or Homabay or whatever, maybe not even that far, even a level 5 hospital, talking about these things is nice. But is it realistic? I think the fact is it isn't. However, we must know, when we started practicing, isotretinoin was something that was used like far away. We talked about it. When we are doing postgrad, that's the time we are doing clinical trials. It was being passed by FDA several years later. But now we have it. We have it even in generics. Of course, like my good friend from Egerton mentioned, the range of, say, from the original drug of 16,000, 17,000 to 5,000 is big. Even 5,000 shillings a month is big for treatment. And when you send the patient to a pharmacy, they have to get an authorization from the insurance or even from NHIF. So these are hindrances. Now, having looked at, you can't see it so well when you are there, but these are going to be sent to you. If you have a smartphone, you can actually expand these things. Because the first box, which you can't see very well here, except maybe when you come from this close, talks about the tumor necrosis factor. We have them in this country, but obviously, like many have said, we have limited access simply because of cost. The other thing is not actually just cost. Actually, there is limited knowledge, and actually among us, because many of us are not actually very convinced or keen to use them, simply because maybe we don't have enough support on that case. And as maybe one of the questions that came earlier along is that we should actually arrange symposia for such things, particularly because even if you are not going to use this, these are things that may come very close to you. So we'll talk about the non-biologics very quickly. The clinical burden of disease here, and this is where maybe we come in also. It is a systemic disease. In the US, it affects more than 8 million people. What about Kenya? The last systemic survey was done in Kenya way back in 69, 70 by one of our lecturers, long gone. And we need now that we have representation virtually in most parts of the country to make a multicentric review of psoriasis so that we can now put it on the map. It's so embarrassing to hear that somebody, a tourist, has come over Masai Mara, then takes 2 days off. You probably might know that, friend. And does a survey of a village in Masai land, and then says, actually, psoriasis does not exist in Africans. And you are ashamed because you people are seeing psoriasis every day. And psoriasis is from coast to the lake, from seaside to the mountain, and in between. Because the spectrum we have of, I think, 2 WhatsApp groups of patients and clinicians, we have close to 300. We have had meetings in Nakuru, in Kisumu, in Nyeri, in Mombasa, and there are patients there. But we need to tell the world about that. I will probably talk about that so that we see the roles that we play ourselves here. Now, one of the problems you saw about the classification, they're saying that classification is the one that enables you to plan treatment. That's very good. It's good on paper, it's good on research. However, we were also reminded, I think this morning or yesterday, I think this morning, the palm is 1% of the body. But for a surgeon I'm treating with the palm and some 2 fingers on the left, he's disabled. He can scrub, he can operate. He's absolutely disabled. And he has had a training in surgery, so he can do that. So it's actually not the percentage. It's also the perception of the patient and also how you can relate to that patient yourselves. So extensive involvement of even some small parts of the body. If you had genital psoriasis, I'm sorry, there can be total disability, isn't it? And breakup of a relation, because many people think that is an STD, they think it's AIDS. And the patient who see you will probably have had the AIDS test many times and they are told it is negative. It's negative. They had had treatments for syphilis severally, but of course it's not going anywhere. I think it is important also that we notice some of those things. The risk factors have been very well described by the past speaker, but I think what is important that we underline is the psycho-emotional well-being. But here is affixed. It's not the psychology of the patient who is disabled. It's actually psoriasis that makes it. If we talked about the cytokines that we talk about in the inflammatory process, and they are actually generalized, so they are actually having an effect in the endothelial cells of the whole vasculature, then it is not surprising that there will be a psychological or even emotional disability or being. It is now well documented that suicide ideation is actually pretty common. In Philippines, actually, we have had many deaths. And being at the international level, we come to hear of these reports every now and then. So what is the crux of the matter? It's early diagnosis. And early diagnosis can be made everywhere. Whatever clinic you are in. And I will not emphasize that you have to do a diagnosis. A biopsy. Waiting to do a diagnosis biopsy, I think, is an overkill. There has to be, and I liked Dr. Kiplono's message that you have to correlate the clinical picture with the histology. Okay? It's so important. Yeah, there are many diseases that we present with the parakeratosis, even acanthosis. one may not probably have probably just eosinophils. But there are also other diseases that may appear like that. And if you consider how much is a biopsy, is that something that we are routinely doing in every clinic? No. And even where it is being done, we don't have a Kiprono there. Because one of the effects, and this is something that we have discussed a lot, is that histological support is important, but is largely actually not present. We do respect to our pathologists, they are very good, but you know, dermatopathology is not, it's a rather specialized thing. And the best dermatopathologist is the one who is already a clinician, because he can coordinate. But if you look, and I have had a look at labs, the clinical detail will give in those lab requests, you know, skin disease is a diagnosis, and then you said some biopsy, you know. So the size and site of the biopsy is also terribly important. I think Dr. Kiprono has addressed that earlier on. Early diagnosis. And then, maybe more importantly, what are the expectations of the patient? Where you've been sitting, and I will not use more time also, is that the patient comes in an expectation, and you have to address that expectation. Many have come over thinking that they will get a cure. They can't cure them, but you can manage them and help them to manage their lives and whatever. The other thing, of course, we have probably overlooked are the carers, the husbands, the wives, the parents. They are an integral part of the management of the patients. What is the view of the health carers? You know, we were told here that there are people who see skin disease and say, no, that's not mine. Send it over to the other person who sees those type of things. So we need also to have a knowledge, skill transfer among all healthcare workers. I think it's important. Very, very quickly, money and outline are the same. I don't think it is fair to say that steroids are out or steroids are contraindicated. We know very well guns are contraindicated in any country, including Kenya, but they are licensed, isn't it? In the proper hands, they are very useful, they are protective, but in the bad hands, they can be very, very dangerous. Now, the systemic ones are the ones that I think we need to probably just spend a little bit of time here, because this is something that is not fully utilized. It's available, not so expensive. And the action can be used even in some of the centers. However, when you are going this way, then you must be certain that you have actually performed all the tests, because you go to the pharmacy, like I said, and they are told we are using cancer drugs. What cancer do you have? And you have that, and you have a conflict already. What is commonly available is methotrexate, with all the concerns that have been expressed. I will not repeat that. Cyclosporine works pretty fast, faster than methotrexate. Methotrexate may be more than a month. Acetretin actually is better than isotretinoin, but isotretinoin is much cheaper and commonly available, but with all the monitors that we need to do. I haven't used fumarate. They are very much available in Germany and part of Europe. Azathioprine, I do not know who has used it, but this is something that you see. I put a Primalast last year, but it is something that we are doing studies here in this country. It's a Nolo tablet, 30 milligrams twice a day. It's effective. Patients will look for something which is convenient and fast, and it will be available hopefully very soon through one of our persons. These are the non-biologics. And these are things, good monitoring you can do. Obviously, they are cautioned. If someone has generalized infection, they are cautious. If they have comorbidities, that is where you go. Because comorbidities actually reduce, they do not just actually increase morbidity, but they actually reduce the longevity. In our June-July meeting, we honored Neil Mehta and Joe Gelfard. These are familiar names to the people who know about psoriasis, who have pioneered work on the vasculature in the body and actually indicating that psoriasis actually involves the whole body vasculature. And we had a live lectures from them. This will be available, hopefully, like somebody asked in one of the questions that was sent, that we could have focus sessions just to deal with these things. So a Apremilast looks like it's far off, but we'll soon get it and it'll be available. Now, obviously, when you are talking about other things, yeah, we are talking about, and Professor Muyao has gone into this, Dr. Kakuru has gone into this, the American Academy of Dermatology recommendations. Somebody with psoriatic arthritis, they have to get a systemic treatment. We have the ones that we have, the ones that are available. If you monitor them, if you do the right investigations. The classification of whether moderate or severe is actually with you and the patient. This surgeon that we have, we are using a biologic at great cost to him, but he's going to turn around, okay, and be able to work. So you have the topical agents, UVB, but you know, actually during this COVID, how many are able actually to travel for phototherapy? It requires so many sessions, in 1 week or whatever. It is costly, whether somebody is using bus fare or whether they are driving or whether somebody is paying for them. Biologics are useful. I think what I want to underline here is that we have, we need to involve other people than just ourselves. We have the dermatologist, we have the primary healthcare workers that actually many of us here are, and you have the nurse that coordinates some of these things. Some of those patients will be referred for endocrinology workup. They have maybe diabetes, or they have other illnesses, gastro. If they have inflammatory bowel disease. And as somebody did say, biologics are actually not absolutely contraindicated in IBD. Actually, that might be one of the pivotal indications. Ophthalmologists, how many ophthalmologists would diagnose psoriasis? It is us to do that. The cardiologists, fortunately, we work in a team, but how many of us have referred patients to psychiatrists because of psoriasis? I think what we now need to talk here maybe are the psychologists, because we need to have them address chronic illness or chronic disease, how to manage that. And of course, rheumatologists. All this, the patient is at the center. So we are all being patient-centric. So collaborative care in psoriasis is important. Many of these, clinicians that have referred may not actually be very, very, very vast with the dermatological problems. However, at the bottom, when you say that there are progress in treatment options, there is a considerable care variation. Difference because of the way we are positioned, but you can still make a way of that. I think the most important thing here is knowledge and skill. Knowledge you can get that even from the journals, from the emails that we are having. We can also read and transmit. But then we need to develop another skill of how to get a rapport quickly with the patient, and also a rapport also to be able to interact with our colleagues also. That's so important, because that way then you make the life a little bit better. So suboptimal disease care is what we are seeing. We need to be a little bit more holistic. Patient and physician agreement regarding psoriasis severity assessment. The treatment goals extremely important, and improving the care with training and communication skills. More importantly, patient education, disease training. We will hopefully participate in these things. I'm just finishing up. We have the Global Psoriasis Atlas that I have addressed KD severally, where we are forming. I think some of you may be familiar with the Diabetic Atlas. It's something that comes up every few years. This is a mapping of the epidemiology, of the management tools, of the treatment that are available around, and we can get into that Global Psoriasis Atlas. Okay, that is something that we need to be getting. We have resources from the International Psoriasis Council. We have GRAPPA, and I'll finish off. Of course, finally we have IFPA. This is a patient association. Our chairman is a pivotal founder. He's traveled talking about psoriasis in this country and elsewhere, and for which we are grateful. I want to thank everybody here, particularly KD officials, for participating in the treatment of patients, particularly that knowledge skill that patients are getting the right messages. Let me finish there so that we can have questions and discussions.